Clinical Key is our newest tool, so that's a medical search engine. I think you guys all sort of got it in med school. So yeah, you can continue using that because you get it through BMA membership as well. What else is there? Part of membership, you also have access to our clinical, non-clinical learning tools. So you have full access to BMJ Learning, which has over 1,000 clinical, non-clinical modules. And also there's lots of courses and modules helpful for completing your e-portfolio as well when you begin F1. It's all very interactive and kept up to date with lots of practice changing developments as well. And for each module we do, you can print off a certificate as proof of learning. Very early for this, perhaps, but if you're thinking about your specialty options already, you can use our Specialty Explorer tool, which can help you get a bit of a better picture of what suits you best. So it's an online psychometric test which takes about 20 minutes to complete. It'll ask all sorts of work-life balance questions, then it'll give you a detailed report listing the top suited specialties according to the answers you've given. It's really, really easy to use and covers all UK specialties. And the reports are always very thorough with lots of analysis and graphs of your answers. Sorry, that's my dog barking at nothing. Yeah, really good to do just at different stages. So now, then maybe in a year's time, then sort of 6 months after that, and just see how your tastes change and which specialty sort of suits you according to the answers you've given at that particular time. We have a really good wellbeing service. So anytime you feel you need to speak to someone about your wellbeing, our services are open 24/7, and you'll have the choice of either speaking to a peer support doctor or a counsellor. It's a telephone-based service, and we do offer video calls as well if you prefer that. We'll also make sure you speak to the same counsellor or peer support doctor as well if it's more than a singular call to the service. Completely confidential, free of charge, and open to everybody. So regardless of whether you're a membership or not, anyone's free to use it anytime, day or night. Probably the most key tool that I would hope that all you guys use in the next sort of month or two is our contract checking service. You may have heard of it. Save you a lot of time, potentially quite a bit of money as well. And yeah, definitely the key tool for me to sort of to tell you about today. I don't know, knowing the NHS, you probably haven't got your contracts yet. You may not get them for another couple of weeks still, although you should really have them now. But yeah, once you do get them, we'll send it to us. We'll aim to check it within 5 working days, comparing it to the model which we negotiated back in 2016 and then again in 2019. And if there are any issues, we can help get them sorted. So I'm not saying it's always on purpose, but extra bits can be, we've seen this, extra bits can be slipped into your contract, or the words sort of changed to mean something completely opposite to what it should say. And yeah, we just want to make sure your contract's correct and you're getting what you should be. So yeah, sadly, 25% of the contracts we checked last year were wrong. So 1 in 4, and it's just a massively high number. So do join at least until October and get it checked, preferably before you signed it. If you signed it, and we can still check in, if it's wrong, it's wrong. You should never have been given a wrong contract. We can still sort of help and rectify that. But yeah, you can also get your rota checked as well. So we've got an online tool where you just input your rota and it flags up to us if it's wrong. But rota is a bit more standard, so you shouldn't have as many problems with that. So just a few figures. It wasn't a few contracts we checked last year. We checked nearly 6,000. So 25% of those being wrong was just a ridiculously high number. So yeah, so do join, get your contract checked, preferably before you sign it, like I said. And yeah. We managed almost 21,000 junior doctor cases last year. So we've seen most things before. And if you find yourself sort of needing some support in any way and sort of facing any issues, you can come straight to us and we'll help you through. We've got great people at every trust. So we've got industrial relations officers, we've got employment advisors based at every single trust around the UK who know sort of HR and who they need to know to get things sorted ASAP. And we can help sort of support and give you some protection. Also, we check 1,600 rotas. Rotas should be pretty more standard, like I said. Should be less room for messing up there. I was going to say a different word. And yeah, that's it from me, really. So yeah, as I mentioned earlier, if it's a good day to join, if you use that QR code on the screen or a link in the chat, you get 3 months free, which allows you to get your contract checked, your rota checked, get involved in sort of the ballot. Hopefully it'll be sort of October, November time. And then yes, sort of look at sort of industrial action, strike action towards the end of the year. So yeah, sign up if you're not already signed up. Get 3 months free, get your contract checked, and that's it really from me. Thanks, and I will let you get on the session. Actually, I think you're going to hear from MDU first, aren't you? But yeah, thanks for listening. And yeah, do join your union.
Right. Thank you, Daniel. So yeah, it's really important to join the BMA and the MDU as well, which will protect you from any litigation once you start working as a doctor. I'm just going to play a small video from the MDU because we don't have the representative yet, but they've just sent the videos. So I'll just share my screen now. Okay. I'm going to share my slides for my presentation now. All right, yeah. So welcome everyone. Again, so today's talk is part of a talk of our FY1 Survival Guide on DNACPR and Verifying Death. So my name is Hamza Duffaydar. I'm a junior doctor working in the West Midlands today. This talk will aim to host this talk over an hour. So feel free to put any questions in the chat box and we'll try answer it at the end of this talk. I'll also post the feedback, the link for the feedback form in the chat box. So do fill out the feedback forms because it does help us improve our talks, but you'll also get a certificate of attendance on filling this out, which you can use for your portfolio because this talk can count as a non-core teaching hour when you, as part of your FY1 year. So let's start this talk now. So today's content will cover DNACPR, respect forms, a discussion about respect forms with family members and patients. We also have a small section on verifying death and how to document verification of death, and we have a summary at the end. Okay, so CPR. CPR stands for Cardiopulmonary Resuscitation. So what does that mean? That means when you do repeated cycles of chest compression and artificial ventilation, basically to mimic the action of the heart and the lungs. So that's usually done for a patient where their heart or their lungs is not working. So it's a manual effort, it's a mechanical effort you do to mimic the action of the heart and the lungs to preserve oxygenation to the brain until you get ROSC. So ROSC is a common term you will hear when you do your ALS course. It means return of spontaneous circulation. So that means when the heart and the lungs have started working again. So basically, you do CPR to take over the action of the heart and the lungs until you maintain return of spontaneous circulation. As opposed to what many people think, CPR actually has a very low success rate. So the actual success rate of CPR for patients in hospitals is between 12 to 15%. And that's compared to a survey done where most patients thought CPR was successful in 75% of cases. So CPR has a low success rate, and the success rate is actually even lower if performed outside of hospital. If performed by a bystander on the street, the success rate is around 7%. Yeah, so it has a very low success rate. And CPR is quite a violent process. As you can imagine, you're jumping on someone's chest and you're doing compressions. So there's the risk of injury to the patient as well. There's around, in 9% of cases, you can get broken ribs, broken sternum, you can get internal bleeding and pneumothoraxes, both at around 3% of cases. So quite a violent process for patients. And as you can imagine, for older patients, CPR can actually cause more harm than good for them. And I've also put this point about dignity of death. So if you're going to consider CPR for someone, it's important to think about whether you want this patient to have a peaceful death. So if the patient's going to die, whether jumping on their chest within the last few minutes of their life would be best, or just to leave them comfortable and die peacefully. So these are important factors we need to consider when thinking if CPR is necessary for a patient. So now we go on to DNACPR. DNACPR stands for Do Not Attempt Cardiopulmonary Resuscitation. So usually some patients in hospitals will put up DNACPR, and it's a decision made in advance. It's made in advance before a crash call, so then you know which patients you will go on and do chest compressions and which you won't. And it's a legal requirement for a patient to be involved in making this decision and to be informed of this decision, which is made on their behalf. However, the law does say that you don't need a patient's consent to put a DNACPR. So basically what that means is that at the end of the day, it's a doctor's decision. There's a huge misconception that people think DNACPR decided by the patient and the family members. That's not the case. It's decided by the doctors and the team looking after them. But it's always good to have the patient and the family members in agreement with this decision. So when would you consider putting up a DNACPR for someone, or even consider the question? So if you have a patient who you think is at risk of dying, or they've been diagnosed with a terminal illness, you can also consider it if you get an advance directive from a patient. So that's when the patient tells you in advance, I don't want to be resuscitated in the future if anything does happen. And you would also consider putting a DNACPR if you think the risk of CPR outweigh the benefits. So as we talked about earlier, CPR is quite a violent process, especially for elderly patients where you think it won't benefit them to do CPR with the low success rate. You would actually put up DNACPR. And it's good practice to start the discussion early on with the patient if you anticipate there's a risk of them dying during this hospital stay, no matter how small the risk. And then I've put this point about respect forms. So I'll go on to speak about respect form in a minute. So respect forms are a new form that has been introduced in the UK. So it's now available in all hospitals across the UK. And it prompts the clinician to have a discussion with the patient about CPR, but not only about CPR, about the ceiling of care. So what level of care you would give a patient. So this is the format of the respect form. So it's a one-page document, and this is the front and this is the back. And it's quite self-explanatory, but we'll go on in a minute to work through the different sections of it and how you fill out a respect form. So RESPECT, it stands for Recommended Summary Plan for Emergency Care and Treatment. So it contains a summary of personalized recommendation for patients' clinical care in the event of a future emergency. So if anything does happen in the future, let's say a patient has cardiopulmonary arrest, the respect form is usually like it's a piece of document which has recommendations of what to do in the event of this case. So it will guide you. And why is that important? It's because, as you might imagine, patient might deteriorate out of hours. So it's good to have a document from the clinicians looking after this patient, usually during the day, and who know this patient better, to give advice about what to do or what level of care to give this patient if anything does go wrong, because they are in a better position than you are if you don't know this patient to make a decision about it. Respect form also allows us to take into account the patient's preferences, but also the clinical judgment of the doctors looking after them from day to day. And respect form remains with the patient. So even on discharge from the hospital, the patients take the respect form with them and they bring it to the community, whether it be the nursing home, or sometimes you even have respect forms started by GPs. So then when they do come in hospital, they should come in with their respect form, or at least have it on the system. So respect forms will stay with the patient for life. But that having been said, you can reconsider the decision made on the respect form. But the respect form stays with the patient once it's made. They should carry it with them when they come to hospital again. So a respect form, as I said, it prompts a discussion between the clinician and the patient and their family members, just because of the format of the way the respect form is formatted. We'll see that in a minute. And ideally, all patients should have a respect form, but it's more relevant for those with complex health needs. So for those who you think might need mechanical ventilation, for instance, or CPR. Because on that respect form, you can then say whether they would be suitable for this treatment. So now we're going to just work our way through a respect form. This is a respect form I filled out for an imaginary patient. Again, I apologize for the small print, but we're gonna work through it together. So at the top of the respect form, you have the patient's preferred name. So this patient wants to be called John Doe, and their full name, and their NHS number, their date of birth as well, and the address. It's important on respect forms not to put patient identifiable labels, but to actually fill out all these sections in full. This just avoids making a mistake, because as you can imagine, putting in a respect form for the wrong patient can be quite detrimental. And then here you have a little box where you write the date at which you're completing this respect form. So the first section of the respect form is a summary of relevant information for this plan. In this section, as you can see, it's all self-explanatory. It tells you what to put. It says put the diagnosis of this patient, and that's also where you would put the background, past medical history of this patient. So relevant past medical history, which would prompt you to make the decisions which you'll put below. So for instance, for our patient here, John Doe, on this admission, let's say he was diagnosed with advanced metastatic lung cancer. So I've put advanced metastatic lung cancer. He also has a background of dementia, heart failure, COPD, and severe frailty. So that's his list of past medical history, which is relevant. That's why we would make the decisions which we'll come to below. In this section, you can write about organ donation and other stuff, but that's not really important. So I've just left this blank, and in a lot of patients, it's actually left blank. So then we come on to section 3 and section 4. So these are the two most important sections of the respect form. In section 3, so that's where you have the patient preferences. So that's when you would consult the patient, but that's given if the patient has capacity. So on the far end, you have prioritize sustaining life, even at the expense of some comfort. So that's usually in this category, you'll have patients where, for instance, CPR or even mechanical ventilation, where you want to give them treatment, even if you agree that it might cause harm to them. And at the other end, you have prioritized comfort, even at the expense of sustaining life. So this far end is where you want to keep your patient more comfortable. You don't want to start like any invasive procedures, and you want to give them a dignified death if ever it comes to it. So in this section, you should usually circle somewhere between these two. So it's like a timeline. Most people will either circle one or the other, but you can circle in between as well if you think you want both for your patients, like you want a balance between both. So for John Doe, coming back to our example, John Doe who has advanced metastatic lung cancer, we are prioritizing comfort because, as you guys might have noticed, he's quite an old patient with advanced dementia. He was born in 1932. So now we come on to section 4 of the respect form. So this is the most important section. So here, as the clinician filling this out, you would sign in one of these two boxes. So again, on the far end, focus on life-sustaining treatment as per guidance below. So life-sustaining treatment. So if you're planning on doing CPR for this patient, if you think there will be a candidate for ventilation, invasive ventilation, or ITU, or at the other end is more symptom control. So that's, again, keeping the patient more comfortable at rest. So as we discussed earlier, this John Doe, we want John Doe to remain more comfortable. So I've signed here in this section here, focus on symptom control. So the next part of section 4 is where you would specify the ceiling of care. Ceiling of care is quite a common term you will come across as an F1 doctor. That basically means what level of care have we decided we will give this treatment. So where does the limit stop? So as I said, it's by law, it's a decision of the clinicians looking after the patient to make this decision, not the patient, but it would be good to have the patient and their family members in agreement with that. So coming back to John Doe, we said we've decided as the clinician looking after him, he would be for ward-based care and treatment of reversible causes. So ward-based care is we would treat him for anything we can treat on the ward. So anything like a chest infection or a UTI, and those are reversible causes as well. So he wouldn't be a candidate for ITU escalation, as I've said. So ward-based, it means if he does get deteriorate and does need ITU, we wouldn't send him to ITU because given his comorbidities and his age, we don't think he would be best suited for ITU. And then in this section, you should also write your decision about CPR, whether you think this patient would be a candidate for CPR or not. So for him, we've said not for cardiopulmonary resuscitation and not for invasive ventilation either. So invasive ventilation would be in the form of CPAP or BiPAP, yeah. So it's good just to write a summary of potential treatment you could give this patient and where the limit would stop, just so someone else looking at this respect form knows what treatment to give this patient if they do deteriorate. And then at the bottom of the first page, the front page, you'd sign. So for John Doe, we said CPR should not be attempted. So I've signed here. Again, I've put my signature. So these forms are quite self-explanatory. It will ask, you can see it says clinician signature. So I've just signed there. So now we go on to the back of this form. Section 5 is basically asking you, does this patient have capacity? So because John Doe has advanced dementia, we say he doesn't have capacity, so I've circled no. But if your patient has capacity, you would circle yes. And does he have a legal proxy? John Doe, for this case, yes, so I've circled yes. And then in section 6, that's asking you who was involved in making this decision. So in part A, if the patient has mental capacity, it's usually this patient. So you would tick part A if your patient has mental capacity for taking part in the discussion about respect form and sealing of care. But if your patient doesn't, if they lack mental capacity, then you would tick Part B. So for our patient, we've ticked Part B. And then it also asks you about to list the details of anyone who's been involved other than the patient in making this decision. Because our patient does not have capacity, I've put down the name of their next of kin, Jane Smith, who is John Doe's daughter. Part 7 of the respect form is where you'll need the signature of the clinician filling this out. So in this case, this has been myself. So you put your grades, I'm an F1, my name, my GMC number, and my signature, and date and time at which I completed this respect form. And it's also important to know that a respect form is only valid if it's countersigned by a consultant or a ST3 or above. So that's a registrar or above. So as an F1, F2, just filling out a respect form by yourself wouldn't be valid. It will need to be countersigned by someone. But the reason I'm teaching you this today, how to fill out a respect form, is because in the majority of cases, as you might imagine, your seniors won't have time themselves to fill out their respect form. So they'll give you to fill it out, and then they'll just countersign it at the end. So in this case, I've put down the name of an imaginary consultant, Dr. Brown, who's also countersigned the respect form. And in section 8, you can list emergency contact details for this patient. So Jane Smith, who is this patient's daughter, and her telephone number. So that's this section is used usually if in the event if there's a harmful event to this patient, it's quick access, so they can use this section to contact his next of kin to inform them. Okay, so now we move on to respect form discussions. So I'm going to give you some tips about discussing respect form. So it's important to give both the patient and their relatives time to process their diagnosis. So let's say, coming back to our example of John Doe, for instance, if someone's just recently been diagnosed with, let's say, lung cancer, you want to give them time to process this information. You wouldn't jump in straight away and go to them and start discussing respect format. As you can imagine, it's quite a grim process. So just give them some time to process the information, maybe a day or two, if you have time to spare and you see the patient is stable. And it's important to start the process early on because that gives the patient time to process the information, to consult their family members as well, and to think about their future. And if the patient has no capacity, as was in our example, you should consult the next of kin, so at least make them aware of the decision that has been made. But again, as I stress, it's good to have the patient's family members and the patient in agreement with your decision about DNACPR. But at the end of the day, it is the clinician and the team looking after the patient who makes this decision about sealing of care and DNACPR. So now quickly I'm going to run through a DNACPR forms. So I've not personally filled one out because usually if your hospital will have a respect forms have now replaced DNACPR forms. But I'm just running it through in case you do come across it, but I doubt you would. So DNACPR forms are actually easier to fill out than respect forms, but it's basically the same thing. You put the patient details here, patient's name, their NHS number, their address, and their GP practice. And then in this section, you would tick whether you think this patient has a realistic chance of surviving if CPR was done. So for our patient John Doe, I don't think CPR would give him a realistic chance of survival if it was performed. And you need to say why you think so. So I've said here because he has severe comorbidities such as COPD, heart failure, frailty, and old age. And then the rest of this DNACPR form is just tick box. So it's just have you discussed it with the patient, and yeah, has the individual been made aware of this discussion? And then here you would sign, and again get a consultant or reg to countersign. So yeah, it's basically the same principle as a respect form. So now I'm going to quickly run through an example of how I would discuss sealing of care and have a respect form discussion with John Doe's daughter, just so you guys have an example. Yeah. So in front of me, before I start this discussion, I just have some information about our imaginary patient, just so I have it all at hand. So we have John Doe. He's a 90-year-old man, and he was recently diagnosed with advanced metastatic lung cancer on this admission. His past medical history includes dementia, COPD, heart failure, and severe frailty. And his next of kin is his daughter, Jane Smith. So the decision about his sealing of care was made by the team looking after him, which was led by Dr. Brown, the responsible consultant, let's say a respiratory consultant, for instance. And what have we decided for John Doe? So we've decided that he would be for ward-based care and treatment of reversible causes, and he wouldn't be a candidate for cardiopulmonary resuscitation, so CPR. He wouldn't be a candidate for invasive ventilation, nor a candidate for ITU escalation either. So for him, we just want to prioritize comfort. So I'm just going to run through an example. So just pretend I'm ringing the patient's daughter. Hi there, my name is Hamza. I'm one of the F1 doctors working on the respiratory team. I'm one of the doctors looking after your dad, John Doe. Is this Jane Smith? So again, I just confirm whether she's next of kin to our patient. And let's say Jane says, yeah, she is. So Jane, would you mind just telling me what you know so far about your father's diagnosis? So let's pretend Jane tells me that she knows her father has been diagnosed with advanced metastatic lung cancer. All right, thank you, Jane. Yeah, so as you're aware, your father has, we've recently found out that he has advanced lung cancer. But the reason I'm calling you today is I just wanted to have a discussion about the sealing of care and something called the respect form, which we've put in place for your father. Would that be okay? So again, ask the patient or the family member whether it would be the ideal time to have this discussion with them. And let's pretend Jane says, yeah, she's happy to have this discussion over the phone right now. So Jane, as you're aware, your father has been recently diagnosed with advanced lung cancer, and he also has a background of advanced dementia, COPD, heart failure, and he's quite frail as well. So the team looking after him, which has been led by Dr. Brown, the consultant, and we've decided that in the event if something does happen to your dad, such as if his heart was to stop beating, we wouldn't jump on his chest and start CPR. So CPR, as you might imagine, is quite a violent process. It involves, it can have several harmful effects, such as broken ribs, and it's only actually successful in around 12 to 15% of cases. And we don't think your dad would benefit from CPR. That's why I just wanted to have this discussion with you to make you to see if you would agree with our decision. Also, because your dad is quite frail and he has COPD as well, we don't think he would be the best candidate for ITU or invasive ventilation, which again are both harmful procedures. But that having been said, we would still treat your dad for any reversible causes, so anything, for instance, like any chest infection or urinary tract infection, anything we can do on the ward. We would still give your dad full treatment on the ward, but we're just saying we wouldn't jump on his heart if, in the case if his heart was to stop beating, or we wouldn't ventilate him if his lungs were to stop. Would you agree with this decision, Jane? And then let's pretend Jane has agreed because she knows her dad is quite frail and all. So then I would just thank the patient, and then I would document my conversations. It's really important to document your conversation with patients or next of kin regarding respect form. You'd be surprised, a lot of patients actually don't want CPR or their family members, because if you do explain it well, that it's a violent process and it has a low success rate, a lot of patients coming to hospital actually want to be kept comfortable, especially the older patients you have who have severe comorbidities. So it's quite important to have a discussion with the patient and the next of kin. So this has been our section on respect form and DNACPR. So we'll now move on to the next section of our talk, which will be on verification of death. And I'll also run through how to document verification of death. So as an F1 doctor, verifying death will be a common scenario you'll be called to the wards to do. So who can verify death? Usually, so all doctors can verify death. And sometimes you can have some, in very few cases, you can have some specialist nurses who can verify death as well of a patient. But most of the time it falls to the job of the F1 to do it. So some tips when verifying a patient's death. Usually I allow some time before I go verify the patient's death. So I leave at least half an hour to 45 minutes after I'm called by the nurse, because as you might imagine, like the patient is, if the nurse knows this patient is dead, there's no pressing need to do it straight away, especially if you're on call. There are more important jobs to do, but also allowing this time to pass makes it easier for you when you go verify this patient's death. So if you go verify someone and they're freshly dead, they might still be warm. You might still hear some gurgling or some respiratory sounds, and this might make you unsure about whether this patient is dead. Whereas if you you wait for around half an hour to 45 minutes or even longer, when you go verify the death, you'll be more sure of it. And it's important to allow time as well. So whilst allowing this time, you can give family members time to grieve by the bedside and to spend time with their loved ones. One important thing to do is to check with the nurse who's called you whether it's the right patient and whether this patient's in the right location when going to verify this death. The last thing you want to do is walking into the wrong bay at 1 in the morning, thinking this patient is dead, and then being startled to death when you actually have mistaken the patient for someone who's alive. So yeah, make sure it's the right patient and it's in the right location. And given that we're still in the COVID pandemic, so this could not be more relevant, don't forget to wear your PPE to go verify death. So just protect yourself as well. Important things to carry with you when going to verify someone's death. So you'll need your stethoscope and a torch. So you can usually carry a pen torch, or I usually just carry my phone with me, and then you can use the torch on there. But I'll come to that in a minute to tell you why you'll need these two equipment. Okay, so how will you verify someone's death? So there's no fixed way of doing this. What I mean by that is you can do any of these steps in any order. So there's no order of doing this one first and this one second. You'll all develop your own personal style of doing it. So what I usually do, the first thing I do when I walk into the room is I just see if there's any response to voice and touch. So the same as you've been taught in ILS or ALS, I usually shrug the patient's shoulder and say, hello, hello, can you hear me? Just to see if there's any response. And if there's no response, I then go on to check any response to painful stimuli. So painful stimuli you can use or supraorbital pressure, so just applying pressure above around the orbits, or sternal rub. So again, it needs to be painful because you want to check if this patient's dead. So do apply some hard pressure supraorbitally and on doing the sternal rub just to check if there's any response. Next, I go on to check the pupillary light reflex. So that's when I use my torch, my pen torch or my phone. So I'll shine a light in their pupils just to see if there's any reaction to it. So if the patient's dead, their pupils will usually be fixed dilated. There will not be any pupillary light reflexes. Then I go on to check peripheral and central pulses, and this should be done for at least a minute. So I go on to check both. Some people just check central pulse, but I just check both just to be sure. So the peripheral pulse I usually check for radial, and central pulse you can check the carotid or the femoral pulse. Again, as central pulse, if this patient is dead, so do press a bit hard just to make sure, because sometimes the carotid or the femoral pulses, if you don't press hard and you're quite superficial, you might not feel it, especially if it's a weak pulse. So do press hard just to be sure that there is no pulse. So press for a minute and feel. Then you should listen to heart sounds and breathing sounds for 2 minutes each. So for heart sounds, I usually listen over the different valve areas for 2 minutes, and for breathing sounds as well, just at the back of the lungs for 2 minutes. Sometimes you might think you'll hear like some artifact, but on doing this, on verifying if you're deaf, you'll become quite familiar with what's artifact and what's actually heart sound and breathing sounds. Usually, if the nurses have called you to verify death, the nurses or the HCAs are quite good at spotting someone is dead. So I'd say 99.9% of cases, if you're called to verify death, this patient is dead. But just be sure, just run through these steps to be sure, and to cover your back as well. And once you've completed this examination, it's important to check the time, because the time of death will be the time at which you have certified the death. So the time at which you have finished running through these procedures, not the time at which the nurse thinks this patient might have died. So the legal time of death is when the doctor, or let's say the specialist nurse, has finished the examination. So why is it important to know the time? Because you'll document this in the notes and also in the death certificate if whoever's filling it out at the end. So here I've just given an example of how I've documented my verification of death for an imaginary patient. At the top, I have patient identifiable details because this will be in the patient notes. So the patient's name and their hospital number, these are both made up. But sometimes, in most cases in hospitals, you'll have patient identifiable stickers just at the top. I've written the date and the time at which I'm documenting, and my name. So my name and my position, so FY1, and why I'm documenting. So asked to verify patient's death. So then I go on to write the steps I've done and what I found. So for this patient, I've noticed absent responses to painful stimuli, and I go on to specify supraorbital pressure and sternal rub. Absent peripheral and central pulses. This patient's pupils were fixed, dilated, and there was no pupillary light reflex, and absent breath and heart sounds. At the bottom, I go on to say the time of death, so the time at which I finished running through these procedures. So it was 1 in the morning, 10 minutes past 1 in the morning, and it's usually good, good practice to write "rest in peace" at the end, because this will be the last documentation in this patient's notes. So no one else will go and document in this patient's notes after. And again, as with any legal document, sign it with your name and your GMC number. So this is us done with verifying death and how to document verifying death. So this is the end of our talk. So just to summarize, we've gone through DNACPR, we've run through respect forms and how to fill them in. I've run through an example of how to discuss respect form with patients and family members. And then the second part of this talk was about verifying death and how to document verification of death. Just a reminder, this talk is part of our FY1 Survival Guide webinar series. So we've already done quite a few of our talks already. I forgot to say, this talk will be recorded and will be available on the Mind the Bleep YouTube channel for you to watch again. But we have two upcoming talks. So our next talk will be on preparing for on-calls and common bleep scenarios for FY1. This will be delivered by my colleague, Dr. Nihal Chanyan, on the 14th of July. And our last session will be on managing the deteriorating patient, and this will be run by a MedReg. So both important talks preparing you for life as an F1. Mind the Bleep is also running in-person courses which are free in Liverpool, London, and Sheffield. And from previous years, it's been shown to have to receive good feedback. So be sure to check out the Mind the Bleep Facebook page and their website for these free courses which you can sign up. So here I've just put up the QR code for this session's feedback form. So on filling out the feedback form, you'll get a certificate of attendance, and you can also put this in your portfolio. So please scan the QR code. I'll just post a link in the chat box as well, so you guys can fill out the feedback form. And please do put out your questions in the chat box now, so then we can run through the Q&A session. So I'll just stop sharing my screen. Yeah. Okay. So I've put the link for the feedback form there. So I'm just going to run through the questions. So put your questions in the chat, and then I'll answer them as we go along. So Sama has asked, can a verbal request from the patient overrule their respect form? No. So if a respect form or DNACPR decision has been made by the team, the patient can, sorry, I'll just charge my laptop. I don't want to run out of battery. Yeah. So the patient or their family members, they can make a request for a second opinion from another clinical team, but they have no legal say in this decision. But as I said, it's always good to have the patient and their family members in agreement. But yeah. And then Sama has also asked, can it be filled out by next of kin should the patient lack capacity? No, so the respect form is filled out by the doctor. So it's filled out by the FY1 or whoever, let's say yourself, if you're filling out the respect form. But if the patient lacks capacity, absolutely, you should consult next of kin. So pretend they're the patient to inform them of the decision you made and try to see if they're in agreement of this decision. Alina has asked, would you get the patient to mark it along the section free scale themselves? So no, you would fill out the feedback form. You would just have the discussion with the patient or the family members and document this discussion. But it's the clinical team that fills out the respect form. A lot of the time, the patient doesn't actually get to see the respect form, so they'll just take your word for what you've told them. They'll only get to see the respect form if they're being discharged from hospital, and then you give them the respect form to take home. Because the respect form, as you can imagine, will stay in the patient notes, so they won't get to see it. So Farah has asked, sorry if I've missed this, but is the DNACPR form filled in first prior to the respect form? So no, what I mean is, if you're filling out a respect form, you don't need to fill out a DNACPR form. So respect forms have now come in the UK to replace DNACPR forms. So most of you will never actually see a DNACPR form. Respect forms have come in to replace those. Yeah, but I've just run through an example just in case if you do the few hospitals, if they are, that are not using respect forms. But to my knowledge, all hospitals in the UK have now started using Respect Forms. Okay. So any more questions, guys? Okay, so Alina has asked, would you fill out a new Respect Form on each admission? So that's a very good question. So as I mentioned, a Respect Form will stay with the patient. So if you're discharging them, you will discharge them with this Respect Form. And then if they come into hospital, they should come in with their Respect Form. So you wouldn't really fill out a Respect Form for a patient if they have one already in place and you agree with this decision made from their last Respect Form. But that having been said, in practice, for a lot of patients, you do actually go on to rewrite the Respect Form because their Respect Form has been lost, or they didn't bring it with them on this admission. But another reason you could go on to fill out a new Respect Form is if there is the case where something else has happened. Let's say for a patient who's come in, and initially on their last admission, we thought they were fit and they were candidate for CPR, but then they come in, let's say 10 years after, and the situation has changed now. This patient you think wouldn't be fit for CPR anymore. So you would now fill out a new Respect Form because your decisions have changed. But for most patients, if the Respect Form is still with them and you agree with that decision, you would just use the same Respect Form. Yeah. Any more questions at all? Thank you. I'll just give it a few more minutes just to see if anyone's typing anything up. All right, I think that's all the questions we have. So I'm going to end this talk now. So just a reminder, if you want to rewatch this talk, it will be on the YouTube Mind the Bleep channel. And we have further talks coming along. So be sure to tune into these talks either. But more importantly, I wish you guys all the best for your FY1 coming years. It will be, I'm sure you guys will do great. We've all managed through it. It's it is like a big step, but think of it like now you guys are working, you'll start earning now, and it's quite an interesting job, and that's why we're all in this profession to help people. So all the best for your FY1 years. Now, I hope this talk has been useful to you. Thank you.